Good morning, Dave. How you doing?
Good morning, David. How are you? I know Mort's
Great.
on the panel. We were
Hi,
listening
Dave.
to all that great instruction from Yakubov's case, so I think we got some ideas on how we want to do ours. We welcome you to Honor Health in Scottsdale. I'm honored to bring cases to this meeting, to Sky this year. I'm going to get right into it because we got a lot going on. In the lab here, we have three of the pillars of our lab. Kendall, who's been with us for 2 decades. We have Brittany and we have Tracy. These guys have done a fantastic job, and I think they're going to do a great job today for us. I'm joined by, to my one side, Dr. Robert Riley, our CV surgeon. To my other side, Venkatesh Ramaya, one of our vascular specialists. We also have Alok Sharma and Bimal Padalia, and a lot of other support people in the room. Let's get right to the case, because what we've tried to do is provide the most interdisciplinary case that we could come up with. Next slide. This is an 85-year-old with multiple risk factors for coronary artery disease, presented with dyspnea and angina. Also, and you'll see where this comes into play, severe peripheral vascular disease. Echocardiography shows a modest reduction in ejection fraction at 45%, and he meets the numeric thresholds for transcatheter heart valve implantation or surgical valve therapy with aortic stenosis, and you see the medications at the bottom. Go next. Coronary angiography performed several weeks ago. Here is his right coronary artery. Nothing there stimulates the oculostenotic reflex very much. Go next picture. The left coronary circulation in the AP cranial view, you really don't see much. You see a lot of calcium. But if you go to the next picture, in the caudal angulations, a very different picture begins to emerge. You have heavy calcification, left main lesion extending into the LAD and circ. I think this is as close to a 1-1-1 Medina as you're going to get, with eccentric calcium extending into both the AD and the circ. Go next. And then the caudal views, you see just how much calcium occupies the lumen of that LAD beyond the main. Go next. Syntax score, 24. Okay, maybe favorable for a coronary intervention. Syntax 2 score you see with the associated 4-year mortality, with the recommendation for PCI based solely on the Syntax 2 score. Go next. So the questions that I would like the panel to discuss, think about, and toss around, in this kind of case, if we are going to do this catheter-based prior to TAVR, transradial versus transfemoral, or both, depending on if you're going to use mechanical circulatory support, and does AS dampen in any way the enthusiasm for MCS? We can talk about that. Lesion pre-treatment, is it balloon angioplasty, or is it high-speed rotational atherectomy? 1 or 2 stent strategy, and if 2 stent strategy, is the DK crush the preferred strategy? Can you bring the camera in? So, but before we get to those questions, Dave, and before we get to the panel, there's 2 other things that questions 7 and 8. Bob, you've got me confused. You brought this case to the heart team, and you said, I think this should be all catheter-based therapies. We have left main disease, we have severe aortic stenosis. Isn't this the historic domain of the surgeon?
Absolutely. It's definitely a surgical case, and for most cases, it still would be surgery. I think if he was 10 years younger, we would obviously operate on him. But, given the talent that we have here and his advanced age, I think that a catheter-based strategy is appropriate.
Yeah, I think, Bob, it shows how functional our heart team has evolved, that a surgeon brings this case to the heart team. A lot of kudos to you for saying, we have the talent to do it. We've done this many times before. You and I have done these left main PCIs together. I think that really is the evolution of the heart team. Vinky Ramaya is no stranger to vascular people at most of the major meetings. We brought you a case with lots of peripheral vascular disease, and while we wanted to do a transradial approach, we talked about, okay, if we want to use mechanical circulatory support, and when we go to do the TAVR, we got a lot of PVD. You want to talk to us about what your role was?
Well, access is the key to all of these large bore procedures that we've been doing for a long time, whether it be EVAR, TVAR, TAVR, or even simply placing a impeller device. So this patient's had a previous bilateral common femoral endarterectomies. His right groin was very scarred. So that's one point against difficult access, and you've got to be aware of it. And the second was his iliac vessels were purely calcified. As you can see in the CAT scan here, David and I looked into it along with Bob, and you can see circumferential calcium, mainly in the common iliac. The externals are pretty good, but right at the junction of the common and the aorta, you can see circumferential calcium with a luminal diameter of maybe 3 to 4 millimeters in diameter. So obviously, Access getting a 14 French sheath, which is not the OD, so if you put the impeller sheath, it's almost a 16.7 to 17 millimeter Access vessel. So we thought that just pushing that sheath in serially without dilators would cause some sort of a dissection or even rupture the calcium.
Can you go to the next picture?
And so we started to use the shockwave therapy. If you look at the angiogram shows luminally the vessel looks really big if you just based on angiographic findings. But we also did an IVUS of this vessel, and you could see concentric, like on the left side of the screen. See, the angiogram looks really good. You can see luminal gain pretty nicely. But if you go back to the IVUS pictures, that segment in the common, you can see circumferential calcium is on the left side of the screen. On the right side of the screen, again, that same circumferential calcium is seen after we treated this with shockwave lithoplasty. You can see the rupture of the calcific ring, and that allows the vessel to distend much easier. And now you can do the balloon angioplasty without gaining any kind of a dissection, and then easily introduce the sheath.
Can you go to the next picture? So shockwave lithotripsy, describe for the audience, for those who haven't seen it, what works.
I think this technology is being used more and more, and I think access into the iliac, especially during TAVRs and other procedures, this is becoming a very important part of the process. Now, shockwave, what it does is it creates an electrical stimulus. That electrical stimulus then is transmitted through the balloon, and then it goes into the calcific wall, and a series of sonic waves occur, which then disrupt the calcium.
I mean, you can actually see the balloon growing
Right.
with each shock, and to the picture to the right, we put it in a bowl of water just to show what it looks like. But I mean, this is really amazing. And with that, you can go live again. You were able to get us.
Yes. Once we did that, we didn't even have to serially dilate it. The sheath went in very easily, and hopefully this gave us access to the rest of the procedure, which Alok and Padilla will demonstrate to you.
All right, let's go live to Alok and to Bimal. So go ahead, guys.
Dave, I had a question. You presented us with 8 questions. You know we only have 45 minutes.
Yep, you guys are going to talk while we work. This is the beauty
Okay.
of having you up there more.
So let me help get the ball rolling,
Sure.
because you got an 85-year-old left main bifurcation calcium, critical aortic stenosis, bilateral femoral calcified arteries. So you've taken the bilateral femoral arteries and treated them already, right? So that's done. If he doesn't have aortic stenosis, would you use left main support for the bifurcation left main rotoblader?
Alok, go ahead. It's yours.
So,
Yes, no, maybe so.
maybe. I think it's always a hot topic for debate, especially in national meetings. We debated about this a lot, and this guy's EF is mildly reduced. He has critical aortic stenosis, and with the left main heavily calcified and need for
Wait,
rotation.
I took the aortic stenosis out. So no aortic stenosis, left main bifurcation, calcified, as we saw. Use support or not?
No, we usually we do not do that unless the patient has, we put a right heart cath, measure their
Okay.
wedge pressures, and then decide. But most of the time we get away without doing it.
Okay, now I'm going to put the aortic stenosis back. Now we've got aortic stenosis.
Well, then I'll jump in on that. Most of the
Okay.
data that we have, whether it's with modestly reduced CF, left main, rotoblader, it's not in patients with advanced valvular heart disease. And that therein changes the algorithm to one of what are you most comfortable with. None of the data we have is, we don't have any compelling data that says what do you do in aortic stenosis patients.
Okay, let me ask, just before I get moving here, the panel. Aortic stenosis, transvalvular PVAD for support of the heart. Is that a problem, or should we just not worry about it? AJ?
No, definitely not a problem and can be done. We typically will only use it in cases where the EF is bad or the hemodynamics are decompensated. We routinely do rotoblader in AS patients without support. The challenge with this case, though, is because of the iliacs, you don't have a bailout.
You don't have a bailout, that's
so
right.
that's the issue. You can, it's all good and fine to say we do it routinely, but if something were to happen and you don't have iliacs to deal with, then the patient, you're going to lose. So I think in this case, I don't fault Dave at all, and I think this is a very reasonable approach.
So it's not the fact that he has aortic stenosis. You can do it with that, right?
Yeah. I mean,
Okay, I want to ask one more question to Dr. Riley. Dr. Riley, he's 85. Do you not operate on 85-year-olds?
I do.
Okay, so what's different about this guy?
Well, it's a combined AVR cabbage, and he actually, I think, would do well for an 85-year-old, but that is with the caveat for an 85-year-old.
Okay, so
Now, I brought I brought a ringer in. Look who I found in the halls.
Holy moly.
Look who I found rolling around in the hall. What happened? How'd you end up here?
You know, my darn flight got deflected over here to Phoenix.
May
so
imagine.
Wonderful.
good.
So-
Welcome, James.
So I brought my ringer in.
Excellent. Well, I was just talking about the fact that the 85-year-old could have an operation, but it carries significant risk. So if he was 75 years old, we would be seeing him in this case?
No, you probably wouldn't, and you wouldn't see him at 85 if we didn't have the talent that we have in the lab here today.
Okay, so he's not going to, my place is going to get operated on, but that's a different story. So let me ask the panel here. 85-year-old
work?
AS,
Yeah.
left main bifurcation, peripheral vascular disease. Are you doing this case, Shami?
180.
We would do the case, and I would proceed first with very similar to this approach. I would put in hemodynamic support, and I would do atherectomy.
Okay, how about
Call
Cindy?
them out.
Yeah, I would do exactly what they have planned, to be honest. I think if you look at the Syntax 2 scoring that David showed at the beginning of
Floor
the case, your 4-year survival is not great with surgery.
Okay.
Can I just interrupt the
I
panel
would
1
say
minute?
one caveat, looking at this and looking at the earlier images, I would have taken the other alternative approach and wired the LAD and done atherectomy from left main to LAD.
Okay, well, why don't you show, that's actually what we did, but we did that off camera.
Yeah,
Why don't you
so-
show them what we did?
So in the interest of time, we just wanted to keep going. So I am right radial. It's a 7.5 French sheathless guide, the OD of which is about 2.46 millimeters, which is similar to 6 French slender glide sheath. We have a right heart cath through the brachial vein. We do most of our cases through the arm right heart cath and the angiogram and PCIs. Let me show the angiogram. We also have Impella through the aortic valve, and we have the new Impella with the smart assist mode, and you will see we have a cardiac
We'll show
output.
some slides on that in a second.
So
One thing I would say is, yes, you can do it with AS, but all AS is not the same. So if it's 0.7 or less, then I do a BAV and put in support. If it's somewhere where I feel that I can get the device across, here was 0.8 to 0.9, I think. I can't remember. It was 0.8, I think.
So watch
And
this
if you can,
device go
cross it.
across.
So his valve area is 0.6. We had a true flow 20 millimeter balloon ready to go if this did not cross, but it wasn't too difficult to cross with the Impella.
I would have definitely done a BAV here. 18 millimeter BAV would be just fine for this case.
That's fine.
Just to change a little
And
bit the tone and
this-
give another opinion.
Yeah, and George,
I
that's
would
a
have
re-
even thought about it.
Yeah, and George, that's a really good point when you say an 18 millimeter, because a lot of the complications with BAV were really dated back to when we were much more aggressive in the sizes of those BAV balloons. If the purpose here is just to facilitate placing of the
Right.
hemodynamic support, then you don't need to go with a larger balloon.
So these are our setup shots. You can see severe calcification in the left main going into the LAD and the circumflex. We wired both of them, and this is our IVUS. We were unable to get even 6 or 5 French IVUS catheter to the LAD. We IVUS the circumflex, and these are the pictures. Could you please run the IVUS? Bimal, do you want to comment on the
Yeah,
IVUS?
Bimal, tell us what you saw on the intravascular ultrasound.
Sure,
Bimal's our
so-
imaging expert. Bimal, tell us what you saw.
You know, as we go from distal to proximal through the IVUS run here, you'll see the distal reference vessel for the circ is about a 4.0. We give it a little bit of flush here, and the images will improve. And the MLA in the circ, almost 360 degrees of calcium, and the MLA is 1.9. As we move closer to the left main here, coming up, you'll see the MLA was measured at 2 millimeters squared, and the reference vessel in the proximal to mid left main is a 4-5 vessel.
So really, it meets the anatomic IVUS threshold for this kind of revasc. So then what did you do? Then you rotated, first thing you did is rotated the left main LAD, correct?
David, can I interrupt for a second? So I think there's some issue with regard to, do we need to do a pre-rotoblator IVUS assessment? You know it's calcified. Both lesions are severe. I think you can rotoblate, and then you can do your IVUS and see what you're working with in terms of size. You don't need to estimate calcium. I mean, it's
Yeah,
calcium.
I would say this more, we actually had a discussion about should we rotoblate the circ or not. And actually the IVUS getting it in there clearly pushed us.
Changed our mind.
Hey, we need to do that as well. And we could debate that, but it was a bit
Oh, that's
helpful.
why,
there.
yeah. Otherwise, I'd agree with Mort that you just take a 175 burr down each way, and I think that would be a quick approach.
So this is a 175 burr going to the LAD. There were significant decelerations over there, right there. And we increased the speed from 160,000 RPMs to 180,000, and then you'll see it moved forward. And then we did a polishing run, and these are our pictures.
We'll definitely move forward.
Definitely move forward.
Definitely move forward.
It was a little gasp on
Yeah,
that last
so-
move, but they're back in their seats now.
Yeah,
And this is our 4 millimeter NC balloon. We had full profile of the balloon, and then we wired the circumflex, and then you guys saw rotational atherectomy of the circumflex, and that's where we are right now.
Okay, why don't you guys work? Herms, what observations do
You
you
know,
have?
I think we had a little discussion about after
Is it on
rotoing
Dynaglide?
the LAD. It looked so good. Did we really need to balloon it? We might fracture it, cause a dissection, and not be able to get back into the circ. But the worst thing you want to do is to do a rotoblator and not know that you can dilate that lesion. So it was dilated with a 4.0 balloon, got a very nice result, and now we're into the circ.
So,
But that bifurcation strategy thing for rota is always a conundrum because exactly as you said, you want to make sure you dilate, but if you have a dissection in the LAD, then the rotablation of the circ thing becomes a lot more complicated. So maybe going a little bit not one-to-one and just ensuring you can expand it, then do the other vessel. There are other strategies, too. You can put a microcatheter in the LAD. You can put a guide liner into the circ to avoid the bifurcation and avoid pulling your other wire. But generally speaking, it's not going to go down.
so Ajay, Mort, team, Shami, talk to me. 1 stent strategy, 2 stent strategy, DK crush, provisional. We know what we had in mind, but we'd like to hear what you guys would say about
The
that.
answer is yes.
Yeah.
The answer is yes.
I would vote for DK crush here, no question.
Based
Well, I
on
would,
what?
it actually has a takeoff that's 90 degrees, and that right where the ostium of the circ is doesn't look diseased to me, so I might consider a T-stent strategy.
Yeah, I would favor to simplify. Is 85-year-olds with severe AS. I would choose a technique that has the least steps, so I'm within the year.
I'd always choose the technique with the least steps, but I don't do this. So
I will
The good
tell
news
you
is he
this
doesn't have
is,
severe AS anymore because he has the impellent.
yeah,
Yeah,
the
and I would say this, that circ is really diseased. It was very tight, it's very calcified.
with an MLA smaller than 2.0.
and-
You know, Herms, you and I have talked about this. It seems like every time we end up in the lab together, we talk about this. And there's, if you ask 8 panelists, you will get 8 answers. When it comes to left main bifurcation PCI, there are so many different opinions. There's some good data out there that suggests maybe provisional. There's some very good data that suggests if you're going to a 2-stent strategy, DK crush is the preferred strategy. I think it's the meticulousness with how they do DK crush. How do you decide?
Yeah, so one, do you need 2 stents? I think it clearly is going to need 2 stents, all right? So how are you going to choose after that? I'd choose what you do best, whatever that is. I think you can do anything right here. I wouldn't do an SKS, of course, but any of the other approaches that have been brought up, fine. I'd do a DK crush, and at the end of a 2-stent bifurcation, you have to make it perfect, and you need to image to make sure it's perfect.
So one other thing, can you go put the slide, while they're working, we're going to let them work, put the slide 13 back up. Yeah, there you go. We're using the Smart Assist platform. It's the new platform. I got to tell you, when I was approached about do we want to get this, I said, we want Impella, we want support. But after I played with this for a little bit, I mean, you get better peak flows. It's a simpler setup. You get LV EDP, you get cardiac power output. That's an important one. Maybe not for the cath lab, but if you have patients in heart failure who are in the ICU, And you get just a number of different advantages to this. I think we are going to make a wholesale conversion to the Smart Assist platform. What are you guys doing at your
We're making
labs?
the same conversion
Okay,
right now. I
yeah.
mean, it's just simplicity of the setup, the extra data, the higher flow. It's
It is really, and the one thing I will tell you with the, actually I'll show it to you in a minute, that you can actually do an exchange. With the old Impella Classic, you couldn't do an exchange and put a new one in. I'll show you in a minute when they're done working that you can actually, it has a wire port, so you can pull the old one out with an 035 and put a new one in, so you can actually do an exchange.
David,
Yeah.
I want to interrupt you. So we're looking at real-time LV pressure on the screen to the right and real-time aortic pressure. Are both pressures from the Impella?
Mort, you know the answer to that.
No. Of course I do, but I'm just asking for the rest of you guys.
Well, why don't we let the panel talk about this?
Okay, so we're looking at the LV pressure, right? And there's only one way to get it in this case, and that's through the Impella. And I guess there's another sensor for the aortic pressure.
Simulated LV pressure.
Yeah,
Let's be extremely clear about that.
Right?
Simulated
George?
LV.
They don't measure it, it's a simulated, they calculate, the calculated LV pressure by knowing the aortic pressure as well as the propelling parameters of their whatever
So it is
device.
not a true measured pressure?
No, they don't measure pressure. They measure pressure, as I said, where the motor is, not this motor though, the aortic motor, which is right above the aortic valve.
No, so more, it's not a true measured pressure, but I can tell you the simulation looks pretty good because you can see the aortic stenosis.
It looks just like
You
aortic
can see a
stenosis.
gradient.
Exactly.
I mean, look at the
And the
gradient.
Very
validation
good.
studies are actually very, you can see the data, but it's quite good in terms
It's very good. It's just to be clear on that.
So, Alok, tell us what you're doing right now.
So we did rotational atherectomy of the circ. So after that, I wired the LAD. This is a 4 millimeter NC balloon in the circumflex. So I have a 4 millimeter stent in the circumflex, 4 by 24 synergy stent, and then I'm going to use a 4 millimeter NC balloon from the left main into the LAD.
Good technique.
Pin the wire, please.
Yep.
This was
Ajay, is this similar technique to what you would use if you were doing this type of bifurcation, or would you have gone, one stent strategy provisional, or would you have done an upfront two stent?
No, I think that's where the IVUS of the circ helps. You clearly see severely calcified plaque, tight lesion, just as Herm said. And once you do that, then you know what your strategy is going to be. So it kind of takes the guesswork out of it, and this is exactly how the case would have been done. It is funny, though. I think my sense of this is that a lot of meetings, people talk a lot about DK crush and that sort of thing, but yet when you see what are people actually doing in practice, I would suspect that people aren't really going through all the steps and that sort of thing. So this is a good strategy.
Well, that's a danger for the DK crush also, because if you don't go through all the steps, you're just not going to get a good result. So that's why Dr. Hellmiller pointed out that you got to do what you feel most comfortable to, and what you do best, you do best. It makes no sense to try to do DK crush and not abide by all its steps.
Yeah.
Herms, let me ask you a
completely agree.
question. Okay,
What size is that balloon in the left main to LAD?
It's a 4 millimeter balloon.
4 millimeter. So I think you're set up perfectly to do the DK crush. And I would say this idea that other steps are simpler, I'm not sure I believe that. And in this particular case, yes, it's AF,
Going up on the
and
stent.
unless you do a one-stent strategy, and that you would do if you thought the side branch is not an issue, I think putting the hemodynamic support has decreased that risk for us. So, so I think this is the way to go.
So let me ask you, the panel, is it that the DK crush inherently is a better strategy, or
Move the
is
table
it the
towards me.
meticulousness and compulsivity with which the study was done and the operators performed? A lot of kissing. They were very, Vimal, you once told me that 70% of the patients in DK Crush 5 got imaging. Is it
Exactly.
just the compulsiveness with which they did this, or is this just simply a better technique?
I think, the panel already alluded to the right way of doing things. And if you want to replicate some of the findings from the great clinical trials, especially DK Crush 5, you have to image.
So I would say, Dave, the control arm in DK
12
Crush
and down.
5 were the same operators who did the same meticulous technique in the control arm, and they that was a two-stent strategy, and in about 20% of cases, they couldn't finish with final kissing balloon. And, and the outcomes, especially in a complex distal left main bifurcation like this one, is unequivocally superior with DK Crush. For
You're
simpler
saying in the
lesions,
provisional
maybe less
arm.
so.
You're saying in the provisional arm of that test.
And with the caveat, DK.
Correct.
Crush, the 5, they were complex bifurcations. The left circ had disease that was significant, right? This was not sort of a one that you would look at and say, well, we're going to cross over and it's going to be easy. They were complex like
Well, what I thought was
Herms,
interesting. Go ahead, Herms, I'm sorry.
Yeah,
They had some of the simpler ones in there as well, but the data was unequivocally superior for when the circ was long and complex.
Yes,
So it's the complex distal left main where the data was unequivocally better for DK Crush 5. And if the side branch was much simpler, it was still better, but the difference wasn't as significant. So I think in that situation, this idea that, well, you know, what about the so the question Dave asked is it the technique or is it the operator? And my answer would be it's predominantly the technique because you had the same high volume bifurcation distal left main operators. You know, to get into that trial, you had to be a pretty experienced operator.
Yeah.
But that brings up the point, is it applicable to the average American interventionalist, though? I mean, we have one center that in China that has been able to achieve great results with DK Crush. Do we have studies from any other center that has reproduced that?
So Cindy, these were 28 centers. So it wasn't single. So it was a multi-center trial, and so it's a great, you know, the comment of do we need to replicate a similar trial in the United States? I think that's certainly a valid question, or anywhere else in Europe.
Just one point just to the audience. Technically, I don't know if you saw this, but after they deployed the stent in the circ and before they crushed the stent, they did a quick test to be sure there was no distal dissection, because what you don't want to do is crush the stent and have the circ have a distal dissection. So you can fix the distal stuff first and then do it if that happens.
Nice.
Yeah. The second thing about DK Crush is, I mean, you can argue the data because it's mainly driven by angiographic follow-up, but we were doing crush stenting beforehand. The reason a lot of people convert is because it really makes the final kiss and the final crosses that you do easier to do, and that's, I think, the most important reason.
May I make one point? I don't mean to interrupt you guys. Did you notice what Alok did? And this is very important. He didn't go to the proximal aspect of the carina to cross back into the circ. He went to the distal aspect of it to cross back into the circ. And that's, I think, a very, very important part of crush techniques, bifurcations, et cetera. Herms, you were going to say something.
I was just going to say, so I think when you're doing a provisional, it's really important to get in the distal cell. I think when you're doing a crush and getting back into it, you have to be sure, though, you don't get so distal that you go outside and back in because you'll pancake that side branch stent.
Yes.
Yeah, actually,
And you
Dave,
actually, if you
Michelle
look where
and I-
you crossed, it actually was, you crossed actually a little
it was in
bit
the proximal,
proximally.
yes.
And so I
Roughly in the
think
middle,
there's
yeah.
a difference
You wanna be
between
crossed.
provisional and the cross with that wire for a crush. And I think
I need a 3
that was perfect right there. I think the other thing that makes DK Crush easier to get back in, as opposed to having 2 or 3 layers of metal that you've got to get a wire through and then a balloon through at the end with a standard mini crush, you've only got 1 layer to get back in, right? You've already opened up that pancaked side branch stent. Now all you have to do is you have 1 layer of the main branch stent to get through. And so your final crush is much more predictable, or your final kiss is much more predictable and easy to do.
Now, with all this roto that we're doing, with all these balloon inflations, et cetera, you see that the hemodynamics aren't budging. The hemodynamics are rock solid. And I do think that in this particular case, that Impella really does add quite a bit to the safety of this procedure. Now, that's my personal opinion.
Dave, one thing actually that's worth talking about is, did you look at axillary access as well? Because I think that there's 2 ways of approaching the support
Right.
cases. When your femorals are bad, you can do axillary, or you can do the approach you chose. I think for many operators, what you've done is probably going to be more accessible than an axillary access. No pun intended, but I was just curious in terms of what your thoughts were.
Well, Bob Riley and I talked about this, and we thought we've considered axillary access, but we're going to come back and TAVR this guy in a couple weeks. And we'd like to do a simple transfemoral TAVR. So Dr. Ramaya, Dr. Riley, and I, Bob, why don't you comment on, you were pretty adamant that we should go transfemoral and litho this.
Yeah, I think that everyone agrees that staying out of the chest or alternative access is the best.
For the TAVR.
For the TAVR. So if we could treat this one time and not have to come back and retreat it, I thought that would be the best, and I think Venki did a great job with that.
Bob, you had something else you were going to add?
I was just going to comment that not only is the patient perfectly hemodynamically stable with the Impella support, but we also have general anesthesia that's doing a great job. And, wanted to know, would you use general anesthesia for this case in general, or for all cases like this?
So the panel, general anesthesia, I see no.
No.
I don't know.
Unless the
I
patient
wouldn't.
couldn't
But that
cooperate.
explains why everything is so quiet and stable there.
No, most no. Let me ask, David, if the femorals are so severely calcified you have to do some very extensive repair, how about a transvenous cable access to the
Okay,
aorta for your
so that's
TAVR?
another option. If we were living in Detroit, somewhere around, downtown Detroit in the Castech area, this would have been a cable. But I don't think this was that extensive. In fact, this was way simpler than doing a cable. Venki would talk to me. I mean,
I think IVUS is what determines the exact calcification and the extent of the calcification and the luminal gain that you get once you've done shockwave lithoplasty. And based on how much of that balloon, we ballooned it almost to 16 atmospheres, so almost created an 8 millimeter balloon, 8 to 9 millimeter balloon. And there was no waste, there was no recoil. Post shockwave and post balloon angioplasty, when we did repeat IVUS, there was no collapse, no recoil at all. And I think even for TAVR, when this patient does undergo TAVR, I think this access will probably be far better than doing axillary access.
and I will tell you, you do what you're comfortable with. Dr. Ramaya did this easily, flawlessly, did a beautiful job. And I've been up in, some of the programs, like the program in Detroit, Bill O'Neill's program, when they did a cable. They do that so smoothly and so easily. So, David Cox, it goes back to what you and I have always said. People do what they're good at. People do what they're comfortable with. And
That's true, but I think, David, it's a little bit more than that, because I think risk-benefit-wise, the approach that you chose is probably honestly minimizing the risk to the patient. I mean, remember before we had shockwave, we would balloon the iliacs too, but the problem is that's more unpredictable because you don't know whether you're going to get dissection or not, and you certainly don't want to stent it before you put the device in.
That's a very true statement.
Hopefully, if the data bears this out, maybe a safer way of doing it.
Ajay, do I take that as a compliment?
Yeah.
Thank you.
It is. And Dave, the other point is right now you can see that left main dissection into the LAD.
Right.
And that's not uncommon with the DK crush. And so you have to sort of be prepared for that, because with that 4.0 or 4.5 balloon that you put in the left main,
You better
LAD,
cover the left main. Yeah, exactly.
So can I just take one step back? You did lithotripsy of the femoral arteries. Are we going to see this for the coronary arteries soon?
Yeah, the trial is underway, or just about to get underway. I know we're a site. Anybody else on the panel a site for coronary? You're a site, aren't you, Herms?
Sorry. Yeah, it's a single-arm trial. It's a registry study, and it's ongoing here in the United States.
I think it's already enrolled.
I wonder why single arm, but
Okay.
how we would know if
kind of a
if you
challenge
really
here,
need it or
actually.
not. I don't know.
So
what were you saying, George?
just to get back to the case, so we did the first kiss, right? And now we're just trying to line this
Going up.
stent up, and I think you've got it there.
Oh, that looks great. That looks great.
So the side branch wire is out, just to remind
Go
everybody.
to epicardial.
So let me ask you this. How many people on the panel, anyone on the panel, leave that side branch wire in when they stent from the crossover from main to LAD?
No.
I wouldn't.
Trapped in.
Everybody pulls it.
I wouldn't. Particularly, you cover all the left main here. That might
I think with the first part of the DK crush, that's the whole thing that you don't need to do that, because there's almost nothing that can then close that side branch.
Providing
It's
you
stented already.
providing
can see
you put
there's
the
no
stent
benefit.
right where you want to put it in a perfect spot, right?
So just to ask the panel, do you think for the DK crush that first needs to be a kiss, or can it be just you open up the side branch with high pressure? Anybody just sort of not doing the whole kiss?
So in CCI, the Fuwai Hospital, they published a series of what they call a double rewire, but without the first kiss. And it seemed to be fine, but there's a lot less data for that than with the traditional DK crush.
Yeah, I'm still two kisses too.
So what we're going to do right here is proximal optimization. So this is a 5 millimeter balloon before we recross into the circ. Test here.
So you want to explain why we pot this thing?
So I think you have to make, the left main was about 4.5 to 5 millimeter, go up there. So we want to make sure that we are well opposed and we don't go behind the stent struts when we try to rewire.
So this is actually going to assist you in getting the wire back into the side branch, correct?
Yeah, so this is the first part, and then after we do the case, we'll do the final part at the end of the case.
Dave's got about 10 more minutes.
Yeah, we're looking actually in pretty good shape. Yeah.
Yeah, you guys are zipping along.
So this is a small point, but I think the sheathless guide is coming in very handy here because of the large size of the balloons that you needed for the kiss.
So if I may make a comment about that.
Very right.
We're doing, I would bet, well in excess of 90% of our left mains with the sheathless guides, 6.5 and 7.5 French sheathless guides through the wrist. That wasn't always the case, but probably for the last 4 years, almost invariably, boy, that looks great. Almost invariably, we're doing these trans-radial. If there's no support, if we don't need MCS, then it's strictly a radial procedure.
That's a good point, but also Don's is a great point because there were so many instances in this case that they did test angiograms and confirmation angiograms and all that. So if you're using a guide that doesn't allow you to see whether there's a distal dissection, this and that, then you got a problem.
Two new 4.0.
We also commonly use a 7 slender in the wrist if you don't have the right shape in the sheathless guide.
A great point.
Yeah. And Dave, to your point about the support issues, it's also important. These are both fantastic examples of great use of support, great cases. Actually, Steve Yakubov texted us and said that he stented the LED with a 4.022 post-dilated and then potted with a 5.0, no compromise of the circ with normal IFR in the LED. But it should also be mentioned that not all left main needs support. If you look at the Excel trial, the rate of support was less than 5%. In the U.S. NCDR experience, support as a whole was 25%, which frankly I think personally is way too high, and you start incurring vascular complications that way.
I couldn't agree with you more. I could not agree with you more. I think when you're committing someone to a 13 or 14 French sheath, whether it's femoral axillary, I mean, it's another procedure. It's another place where things can go south. I think you have to be really, really thoughtful. And if the audience takes 1 point home from this procedure, it's that we entered into utilizing mechanical circulatory support after a lot of discussion,
So that slipped right into the circ pretty darn easily. And, if you were doing a mini crush and you hadn't done that first kiss, that would not have happened, right?
That would be 1.5 balloon or 1.0 balloon.
1.0, and you'd put a balloon up in the LAD to lock you in so you had enough support to get that thing in. This was so easy.
So Herms, 2-step sequential, simultaneous kiss.
So I do two. The way I do this is I do 2-step sequential, high pressure, modest pressure, 10 atmospheres kiss, and then I come back and I pot the proximal portion of it to circularize it, and then come back in with IVUS or whatever your imaging technique and make sure it's perfect.
So Bimal, what's the importance of you're really an advocate of re-imaging, even if it looks fantastic. We're going to re-image this thing?
Absolutely.
Go down to 0.
Yeah. The important thing, especially after you've mechanically disrupted this vessel, is make sure you have no other markers of MACE at the end of the case. But pre-imaging and post, I think pre-imaging is probably the most important.
Up to 8.
How high a pressure are you using there?
So I usually go down, go to the side branch first, go to like 12 to 16 atmosphere, go to the main branch, and then we were at 8 atmosphere at the final case.
You know, on the bench anyway, if you do sort of a two-step where you go high pressure, and then a kiss, certainly on the bench, that bifurcation stent looks much better, particularly the opening into the side branch.
And it's more circular. You get a more rounded appearance.
Yeah.
While they're working, just one last point. Can you, Herms, help me with this?
Yes.
So this is Impella Classic. You couldn't do, if you had an Impella in, you went through all types of iterations. If the Impella stopped functioning, to pull the old one out and pull the new one in. With the new Impella, this little device here, this is a side port where you can put an 035 wire, and it comes out the sheath, and so you can actually just do a replacement. You don't have to commit yourself to a 14 French cook, which we do all the time, but you don't have to commit yourself to a 14 cook in the case you want to replace it, but you just use this for your 035 wire. So it is retrievable and replaceable.
Yeah, that's very nice.
NC.
Also helpful if you haven't been able to pre-close.
Oh, yeah.
So that little dissection at the top, is that covered up, Alok?
Yes.
In the left main? So
Yeah,
we just need to expand the
Yeah, so
stent
I'm
up.
going to use a 5-0 for
You can
final
still
part.
see that little dissection.
Yeah,
Well, this is perfect, and 5 minutes early. Congratulations.
Yeah, so, and the other thing is, I think there was a question, did we pre-close? We did pre-close this thing.
You're not going to stent the iliac at all. You're going to leave the balloon, leave the
Vinny,
event,
Venki?
correct?
No, I think putting in a stent makes it even more difficult the next time you go in through that iliac access. So no stents. We did pre-close, 2 ProGlide sutures, and we'll close them. And the next time, if you need to post-dilate again, or pre-dilate again to get the TAVR in, we should do that. I think we've done a lot of EVARs and TVARs,
Going up.
Stenting, endoconduits, and I think this shockwave lithoplasty is a good option for these bad access patients.
All right, so
Well,
Herms?
the next time around during the TAVR or after the delivery of the valve, you can stent it on the way out.
On the way out, if it's
The
a
key
problem.
is not to do it through a stent, because that can be problematic.
So Herms, we tried to, I got 2 last points, I want you to make one. We tried to come up with the most interdisciplinary case we could, yet do it safely. Is this, I mean, that's the Sky mantra, is interdisciplinary approach. Did we hit the mark on this?
I think, bullseye, right?
Be
Cardiovascular
great,
surgery,
Dave.
peripheral surgery, imaging, everybody's in on this case, and this is the kind of outcome you get when
And a
you
great
put all those
outcome.
brains together.
All right, let me just make one, I got 2 minutes left, I think, I've been told. I want to make one very personal comment. Alok Sharma, we wanted him to be the lead on this case. This is the last case Alok will be doing live with us. He's been doing live cases since his first year out of training for Sky. He, in order to satisfy some visa requirements, is going to have to go to a physician shortage area. Alok, it has been an absolute pleasure and an honor to work with you and watch you mature as an interventionalist. So I think he deserves a round of applause. He's just done a spectacular job. So go get your work done and get back up here, down here to Scottsdale.
Yeah.
Move the table away from me.
So, Dave, this is quite a tour de force. Your 8 questions were posed. Did we get to most of them?
I think he got to all of them, Mort.
I think we got to all of them.
I think so.
I think this is a remarkable demonstration of a number of things that we think about, but we never see in all in one place. And it's,
And Mort, this is, this is a case in your mind, we talked about this, that members of the audience can learn from this and say, with all of the imaging and all of the other things in the interdisciplinary approach, I can go back and do this in my institution?
Yep. So in the last 1 minute, any final closing thoughts for our wonderful live case, Dave? I think the panel's shaking their head.
Everybody's very
Great
happy.
case.
Great case, guys.
So Dave, what is the DAP strategy and what duration?
Okay, Herms, why don't you, if this were your patient, what would you do?
Aspirin, Plavix, and I would, for this guy, I do 6 months. He's 85. He's higher risk for bleeding. I'd give him 6 months, and I wouldn't worry because it's left main. Stent thrombosis with left mains is very, very low, particularly with the way this is going to be looking at the end.
All right, guys.
Hey, Dave,
Have sign off.
Great work.
Great job.
Thank you.
Thank
very
you.
much. Thank
Very
for
great
coming out.
job.